Hello and welcome to Root Cause Analysis of GI Dysfunction, a clinical decision tree for gut-zoomer interpretation. My name is Adair Anderson. I am the Product Marketing Educator at Vibrant Wellness. I'm also a registered dietitian nutritionist with a private practice called Eating with Integrity, where I resolve functional gut disorders like IBS. I earned an undergraduate degree in biochemistry, a master's degree in clinical nutrition from Bastyr University, and I've also completed additional training in functional medicine through the Institute of Functional Medicine. Here is our agenda. First, we'll do an introduction on functional gut disorders. Then, I'll introduce my framework for interpreting gut-zoomer results. Next, we'll take a deep dive into the 3 stages of GI dysfunction. Stage 1, microbiome disruption. Stage 2, GI organ dysfunction. And Stage 3, infection. We'll follow a real case study through each stage to build clinical reasoning skills and confidently apply gut-zoomer insights to patient care. Then, we'll end with a clinical decision tree summary and next steps. According to a multinational study conducted in 24 countries with over 73,000 participants, more than 40% of people worldwide are affected by functional GI disorders. This includes conditions like functional heartburn, reflux hypersensitivity, irritable bowel syndrome, and a lot more. We're talking about the functional gut disorders and not conditions like Crohn's disease or ulcerative colitis here. The study goes on to explain that functional GI disorders are related to any combination of motility disturbance, visceral hypersensitivity, altered mucosal and immune function, altered gut microbiota, and altered central nervous system processing. But what exactly is the root cause of these functional gut disorders? What is causing symptoms in so many of our patients? In my framework for interpreting stool test results, I'd say GI dysfunction progresses through 3 stages. GI dysfunction usually starts as a disruption in the microbiome itself. This is usually the result of the way we're eating, food reactions to gluten and dairy, lack of sleep, relationship problems, toxins, too little or too much exercise. All of these things can throw off the microbiome. It's basically lifestyle-driven problems, which is why most of the interventions we use are lifestyle-driven corrections. Then, over time, changes in the gut microbiome and inflammation can influence the function of our GI organs. In my experience, this can result in decreased stomach acid, decreased pancreatic enzyme secretion, decreased bile production, altered motility, leaky gut, and also altered immune markers. And note here, this is not a disease process. It's a functional digestive problem. It's the functioning of the stomach, gallbladder, and intestinal tract that's impaired here. Now, as it progresses even more and the problem gets even worse, you can have a weakening of the immune system response. And that can lead to overgrowth of harmful bacteria or an outright pathogenic infection. So stage 1 is the microbiome being disrupted. I'm specifically talking about problems with the abundance or diversity of the commensal bacteria. And, great news here, we can measure this using a stool test. Stage 2 is the organs themselves. Specifically, is the stomach making acid? Is the gallbladder making bile? Is the pancreas making enzymes? And again, all that can be measured by a stool test. And stage 3 is when we start to identify opportunistic overgrowth and or infections in our patients. So, which test do I recommend to measure these markers? Well, Vibrant's gut-zoomer, of course. The gut-zoomer is an advanced stool test designed to provide a comprehensive analysis of gut health. Unlike traditional stool tests that focus solely on gut bacteria, pathogens, or a limited set of markers, the gut-zoomer evaluates multiple critical aspects of the gut ecosystem, including archaea, fungi, viruses, and also a broad array of gut health markers. This thorough assessment offers an unparalleled view of gut function and its impact on overall health. The gut-zoomer includes over 115 gut commensals, Shannon's and Simpson's diversity indices, key ratios like F to B and P to B, along with phyla distribution, and risk scores for 14 health conditions based on commensal levels. It also looks at 76 pathogens, including 28 bacteria, 14 protozoans, 15 helminths, 6 fungi, and 13 viruses, as well as gut inflammatory markers like calprotectin of force, but also beta-defensin 2, lysozyme, and MDP9, digestion and immune balance markers like pancreatic elastase and secretory IgA, malabsorption markers like fecal fat, and gut antibodies as well, like tissue transglutaminase, deaminated gliadin peptide, ASCA, and lipopolysaccharide antibody. So pretty comprehensive and broad gut tests. Now, before we dive into the clinical decision tree for gut tumor interpretation, and also to help us better visualize the 3 stages of GI dysfunction, I'm going to introduce a case study that will follow through the 3-stage framework. Meet Jessica. Jessica is a 31-year-old female who is 5'7" and weighs 145 pounds, making her BMI 22.7. She does have a high-stress corporate job as a project manager, uses conventional beauty products, frequently drinks from plastic water bottles, and wears a plastic night guard every night. She gets poor sleep, eats a diet high in processed foods, and likes to graze instead of eating meals. She complains of multiple symptoms associated with functional gut disorders, including heartburn, constipation, gas bloating, and also some nausea. I noted that these symptoms got worse after a stressful move from Maryland to Florida. She has been taking a proton pump inhibitor for GERD for the last 2 years, and has also been taking daily allergy medications to manage seasonal allergies she's had since she was a teenager. Let's dive into the first stage of GI dysfunction, which is microbiome disruption. The key markers of microbiome dysfunction are low diversity indices like Shannon's and Simpson's, a skewed phyla distribution, for example, an elevated P/B ratio or high levels of proteobacteria, low short-chain fatty acid levels, especially butyrate, and low levels of the short-chain fatty acid-producing bacteria, especially keystone species like Faecalibacterium presnitzii and Roseberia. Let's take a look at Jessica's gut tumor results to see what's going on in her gut microbiome. Right away, we're seeing a low Shannon's index, which measures richness, and a moderately low Simpson's index, which measures evenness. Shannon's answers the question, are all the species present? A level of 1.5 indicates that the richness of Jessica's microbiome is currently depressed. She's either missing some species or they're only present at extremely low levels. Simpson's answers the question, is anything overgrown? A level of 0.62 indicates that something definitely is overgrowing. And if I look over at the phyla distribution on the right, I see there is definitely an overgrowth of proteobacteria. Proteobacteria, as you know, is a phyla that houses the gram-negative bacteria that produce the endotoxin LPS. According to the 2015 article cited here, proteobacteria should be less than 10% and ideally 5%, and she is at 21.4%. Holy moly. So that is quite a bit of proteobacteria in Jessica's microbiome. We also see that Firmicutes makes up 56% of her gut microbiome, while Bacteroidetes contributes only 19%. This is problematic because Firmicutes feeds on fat and sugar and tends to be inflammatory. Meanwhile, Bacteroidetes feeds on fiber. Now, looking at the key ratios at the bottom, this is why we want an F to B ratio that is less than 0.9. However, we're seeing that Jessica's ratio is 3.0, another indicator that she has dysbiosis. Now let's check out Jessica's short-chain fatty acid levels. I look at the total amount of short-chain fatty acids first. The reference range indicates we want short-chain fatty acid levels between 45 and 210 micromoles per gram of stool. But unfortunately, Jessica's levels are at 12.3, which is pretty gosh darn low. In addition to total short-chain fatty acid deficiency, Jessica also has extremely low levels of butyrate, only 2.5% when it should be between 5 and 12%. This result is alarming because short-chain fatty acids, especially butyrate, are essential for gut integrity. Short-chain fatty acids are the preferred source of fuel for colonocytes. They modulate the expression of tight junction proteins. They stimulate mucus synthesis and quality. They modulate the immune and inflammatory responses and promote the growth of new cells and the repair of damaged cells. Now, the most common cause of low short-chain fatty acids is a diet low in fermentable fibers. However, sometimes constipation causes a false low by increasing colonic absorption of those short-chain fatty acids, so they're no longer present at the time of stool collection. And Jessica does report constipation. So the way you can rule out constipation impacting short-chain fatty acid levels and to provide additional evidence that the patient isn't eating adequate fiber is to just look at the levels of the patient's short-chain fatty acid-producing bacteria. Here are key short-chain fatty acid-producing bacteria from Jessica's consumer results, including acetate producers like Akkermansia muciniphila and Bifidobacterium adolescentis, as well as butyrate producers, Eubacterium rectali, Faecalibacterium presnitzii, and Roseberia. All of these are low, indicating that Jessica's short-chain fatty acid levels are truly low and likely the result of a fiber-deficient diet. I want to take a moment to discuss Akkermansia muciniphila in more detail. Because Akkermansia is a keystone species, it plays a critical role in maintaining the intestinal barrier, specifically that mucus layer that protects the single layer of epithelial cells that separate the gut lumen from the bloodstream. As the name suggests, Akkermansia muciniphila is a mucin-loving bacteria. It loves eating mucin, which is the primary glycoprotein component of mucus. Now, this might seem counterintuitive. How can a bacterium that eats mucus help maintain it? Great question. Love to answer that for you, and this is where it gets very interesting. Question: have you ever grown basil? I have, and I can affirm that if you forget to prune your basil, it will enter the senescent phase of its life. This means the stems get woody, the plant flowers, the leaves turn really tough and bitter, not great for eating. However, if you prune your basil regularly, the plant keeps generating fresh, vibrant growth. And really, there's a sweet spot here. You want to trim, but not over-trim. You don't want to totally kill your plant. And Akkermansia works in a very similar way. By gently thinning the mucus layer, it signals the goblet cells to produce fresh, healthy mucin. This turnover keeps the barrier strong and functional. Too little Akkermansia allows the mucus to become stagnant and ineffective, whereas too much and the layer thins excessively. Both scenarios can lead to intestinal hyperpermeability. Now, also, given the widespread use of GLP-1 receptor agonists like semaglutide, it's also worth mentioning that Akkermansia muciniphila can naturally enhance L cell function, promoting endogenous GLP-1 and GLP-2 secretion. Moving on to the intervention. Here are all the ways to support low Akkermansia muciniphila. Number 1, Akkermansia loves eating red polyphenols found in foods like cranberries, grapes, and pomegranate. Number 2, berberine. Although it does have antimicrobial properties, berberine also stimulates mucin secretion. Number 3, pu'er tea. This is the same tea that we make green, white, and black tea from. However, pu'er tea has been fermented. Also, number 4, intermittent fasting has also been shown to support the growth of Akkermansia. And number 5, you can now re-inoculate by taking an Akkermansia probiotic. Before we dive into additional intervention, I have a pop quiz for you. What do the Japanese have in their gut microbiome that folks in North America don't have? The answer is enzymes specific for digesting seaweed. According to science, Japanese people harbor enzymes in their intestinal bacteria that help them digest seaweed, enzymes that North Americans lack. What's more, Japanese may have first acquired these enzymes by eating bacteria that thrive on seaweed in the open ocean. In other words, feed it and it will grow. So, if you find low diversity indices, low levels of short-chain fatty acids, and depressed levels of short-chain fatty acid-producing bacteria on your patient's stool test results, what should you do? Well, feed the bacteria you want to see more of. Specifically aiming for 30 types of plants per week, eating fermented foods daily, and including prebiotics, resistant starches, and polyphenols. And here's the evidence. According to the 2018 American Gut Project paper, eating 30 types of plants per week is associated with greater microbial diversity than self-reported categories such as being vegan or vegetarian. The authors use a partial least squares approach to identify several short-chain fatty acid fermenters associated with eating more than 30 types of plants. They went on to postulate that, quote, because bacteria differ in their carbohydrate-binding molecules and enzymes that hydrolyze diverse substrates in the gut, a diet containing various types of dietary fibers and resistant starches likely supports a more diverse microbial community. According to both this 2021 article in Cell and his March 2022 appearance on the Huberman Lab podcast, Dr. Justin Sonnenberg affirms that consuming 6 servings of fermented foods daily improves microbial diversity more than eating a high-fiber diet. Looking at the highlighted section, the authors wrote, quote, "In contrast to the high-fiber diet arm, the microbiota of participants consuming the high-fermented foods diet exhibited an overall increase in alpha diversity over the course of the intervention." This 2017 review article provides evidence that prebiotic fibers feed commensal gut microbes. Reading the highlighted section, quote, "Bacteria possess carbohydrate-binding modules, an extensive set of enzymes that allow for the hydrolysis on a wide variety of fibers. Therefore, having a variety of dietary fibers, for example, cellulose, hemicellulose, pectins, gums, and fructans, as well as resistant starches in the diet, is supportive of a varied gastrointestinal microbial community." And here's a 2019 review article titled "The Effects of Polyphenols and Other Bioactives on Human Health." This article points out that, quote, "The primary mechanism of action of polyphenols was originally thought to lie in their direct antioxidant effects. But it turns out they do more than just that." Reading the highlighted section, polyphenols can impact the composition of the gut microbiota, which are independently associated with health benefits, and gut bacteria metabolize polyphenols into bioactive compounds that produce clinical benefit. In other words, there's a bidirectional relationship between polyphenol and the microbiome of the human gut. Just one more reason to eat a rainbow. As for Jessica, I asked her to keep a diet diary and indicate whether she was getting red, orange, yellow, green, blue, purple, black, or white, tan, brown foods in each meal and snack. And we found that just bringing more attention to color helped Jessica expand her eating pattern to include more variety and more polyphenols. And if your patients are resistant to eating real foods or aren't getting enough from food alone, you can also increase intake via supplementation. Here are some therapeutic ingredients available in capsules and powders shown to feed commensal bacteria and increase microbial diversity in the gut. The next stage of GI dysfunction is GI organ dysfunction. The key markers of GI organ dysfunction include low levels of pancreatic elastase, high levels of fecal fat, the presence of meat fiber or vegetable fiber, low secretory IgA, and biomarkers indicating reactivity to gluten. Let's take a look at Jessica's gut zoom results to see how her GI organs are functioning. First of all, it looks like she's not chewing enough, as both meat fiber and vegetable fiber were detected. Now, under normal circumstances, dietary fibers should be metabolized into short-chain fatty acids, organic acids, indoles, and other metabolites, and should not be present in the stool. Therefore, the quantification of fiber levels provides an assessment of digestive efficiency, highlighting potential insufficiencies in enzymatic or digestive processes. The good news for Jessica is that it appears that her gallbladder is making bile. There is no evidence of fat malabsorption on her results. However, because I suspected maybe some fat malabsorption, I did ask Jessica if she ever experiences foul smelling or frothy stools that leave a ring of oil in the toilet bowl, and she did admit that yes, occasionally she does experience this. But then when I went on to ask her the type of stool she collected for her gut zoomer test, she told me that it was normal and not oily or frothy that day. So these results totally make sense based on the patient report. Moving on to Jessica's digestion and immune balance panel, it also appears that her pancreas is not producing adequate amounts of enzymes. As you likely know, pancreatic elastase 1 does not degrade as it passes through the GI tract, making it a useful indirect marker of pancreatic function. Jessica's pancreatic elastase is at 174.1, indicating exocrine pancreatic insufficiency, and ideally we want it to be over 350. So she has some work to do there. Moving on to secretory IgA, Jessica's Sig-A level is quite low at 373.5. Sig-A is the immune system in the gut, so ideally levels should be around 1,000 to help fight off infection or opportunistic overgrowth. Looking at this result, I'm wondering what is bringing down Jessica's secretory IgA. Well, robust evidence indicates that stress modulates intestinal secretory IgA, This includes physical stress from overexercise, mental stress, including academic stress as cited by reference number 2. Since Jessica's gut Zoomer results indicated digestive insufficiency and a depressed gut immune system, I used it as an opportunity to talk with her about the impact stress was having on her digestion. For example, I explained that when her brain perceives stress, blood flow is directed away from her digestive organs into her arms and legs so she can run or fight. And of course, this makes sense because digesting food is not a priority if you're about to be food. When this happens once or twice a month, not a big deal. However, when patients are stuck in fight or flight all the time and blood flow is always being diverted away from their digestive organs, those digestive organs become malnourished and don't have the energy or nutrition needed to create adequate enzymes, acid, or bile. So I asked Jessica to rate her stress on a scale of 1 to 10, with 0 being no stress and 10 being the most stress, and also asked her how often she feels calm versus stressed. And she reported that her stress level is a 7 out of 10 and admitted that she very rarely feels calm. In fact, she often finds herself holding her breath while working. That's when I shared that vagal experts say we should be in rest and digest 80% of our day. I then provided a list of ways she could strengthen her vagal tone and bring blood flow back to her digestive organs. For example, deep diaphragmatic breathing, gargling, singing, and humming. I also shared episode 44 of the Root Cause Medicine podcast with her so she could hear the same guidance from Dr. Navaz Habib directly. After our discussion, Jessica decided to habit stack and start gargling after brushing her teeth in the morning and the evening, and was also excited to play music and hum along to help her feel more calm while working. I asked if she was interested in nutraceutical support, and when she said yes, I recommended a probiotic with Lactobacillus lactis and bifidobacterium that was shown in this 2018 paper to help activate the vagus nerve. I also recommended she use lavender, either by taking soft gels with Selexin, the orally administered lavender oil used in clinical studies, or using lavender-scented soap, deodorant, or essential oils, or even pillow mist to help reduce anxiety-driven stress. I also educated her on all the ways she can support digestion naturally, starting by turning on a parasympathetic state before meals. I introduced her to 4-7-8 breathing. What this looks like is breathing into the count of 4, holding for the count of 7, and then exhaling for a count of 8. And explained that anytime your exhale is longer than your inhale, it tells the body everything is okay. I also explained that up to 50% of her digestive juices are produced during the cephalic phase of digestion before food even enters the mouth, and encouraged her to breathe in the aromas of her food to stimulate saliva flow and digestion, and also to pay attention to the flavors and textures of her food, which also increases production of digestive juices. I asked her where she usually eats her meals, and she admitted she often eats her meals at her desk while working, so I encouraged her to get up from her desk and eat at a table without distractions, and also to consider making the meal feel more special by maybe saying a prayer or otherwise saying gratitude for the nourishment she was about to receive, perhaps using placemats or playing relaxing music to make the meal feel more special. I asked Jessica if she considered herself a fast eater, and when she said yes, we also got to talk about ways to slow down, specifically putting the fork down between bites, using chopsticks, or eating with her non-dominant hand. When I asked Jessica about the size of her meals and if she ever feels overly full after eating, she told me that some days she is so hungry after work that she eats quickly and often overeats, which makes her GI symptoms worse. This led to a discussion about eating regular meals to balance blood sugar and also to prevent overeating at night. I also introduced her to harahachi bu, a Japanese term meaning eat until you're 80% full, and told her this analogy. Have you ever tried to clean out a peanut butter jar by filling it with water and then shaking it? If you completely fill the jar with water, the water doesn't move much, so there isn't a lot of motion to lift the peanut butter from the sides of the jar. In contrast, if you only fill the jar partway, there's more room for the water to move throughout the jar, creating more turbulence and lifting power. So just like trying to clean out a peanut butter jar, gastric digestion is most efficient when your stomach is not 100% full. We also discussed eating with her circadian rhythm. In other words, eating about the same time each day. I explained that her digestive organs anticipate mealtime and begin making digestive juices before food enters the mouth. As Dr. Satya Panda explained on episode 115 of the Huberman Lab podcast, if you're usually eating breakfast at 8 a.m. and then one day wait until 10 a.m., your stomach will say, the food didn't come at 8, it came at 10, so maybe tomorrow let's be ready at 9. But then if you go back to eating at 8 a.m. the next day, your stomach might not be ready for food by the time you eat. Jessica thought about this and reflected that it's often hard for her to eat breakfast when she has to wake up at 4 or 5 a.m. for an early morning flight. And in these cases, I explained that it can be helpful to use digestive support like taking digestive bitters or using digestive enzymes or betaine HCl to support digestion. Lots of ways to replace digestive juices. You can do betaine HCl and use self-testing to identify the dose, which is the dose right before you get the burning. You can also use digestive enzymes like amylase, lipase, pepsin, proteases. I often use DPP-4 for patients with gluten or dairy sensitivity because it does help break down gluteomorphin and casomorphin. If food sensitivity testing shows broad reactivity, I also choose blends that cover all major food intolerances. For patients with fecal fat, I add ox bile, and if there are liver or gallbladder issues, I may also include TUDCA short-term to get the bile flowing again because, it does take bile to move bile, and when bile gets sticky or sluggish, a bolus of TUDCA can help it get going again. For Jessica, we used a comprehensive formula with HCl, ox bile, and enzymes, including DPP-4. I chose that formula for her because her gut antibody panel indicated high reactivity to gluten. Specifically, she had elevated antibody levels to fecal gliadin and DGP, as well as moderately elevated antibodies to tissue transglutaminase. Additionally, her digestive and immune balance panel showed high levels of fecal zonulin. As you likely know, zonulin is a signaling molecule that tells the tight junctions to open up, so elevated levels are evidence of intestinal hyperpermeability, aka leaky gut. Jessica's GutSummer results indicate that gluten is likely driving her leaky gut, but I also wondered, could there be other foods contributing as well? Which is why another intervention for GI organ dysfunction is to remove reactive foods to help calm any GI irritation. And this can be done, of course, via an elimination diet, gluten-free diet, or informed by food sensitivity testing results. So in addition to GutSummer testing, Jessica also collected a blood sample for Vibrin's WheatZoomer test. The WheatZoomer provides a comprehensive assessment of wheat and gluten sensitivity and intestinal barrier permeability, plus early and sensitive detection of markers associated with celiac disease. The main difference between the GutSummer and the WheatZoomer is that the GutSummer is a stool test that detects antibodies in the gut lumen, with a clinical focus on local immune response, mucosal injury, and endotoxin load in order to assess gut inflammation and permeability along with gut-residing LPS bacteria affecting the barrier. In comparison, the WheatZoomer is a blood test that measures antibody levels in circulation, providing evidence on systemic immune reactivity to wheat gluten and LPS. It aids in the diagnosis of celiac disease, non-gluten sensitivity, wheat allergies, and also detects translocated LPS, triggering systemic immunity. Looking at Jessica's WheatZoomer results, we see elevated levels of zonulin in her blood, along with high levels of antizonulin, moderately elevated levels of antiactin, and elevated levels of human antibodies to LPS. All of these affirm her GutSummer results and indicate the dysbiosis in her gut is impacting her systemically. According to the 2020 review article, All Disease Begins in the Leaky Gut, Dr. Alessio Fasano affirms that the most powerful triggers for zonulin release are indeed LPS bacteria and gluten. Jessica's WheatZoomer results show she does have elevated antibody levels to 2 of the 6 gluten peptides measured, alpha-gliadin and low molecular weight glutenin, indicating yes, she does indeed have reactivity to gluten. She's also reacting to one of the 5 non-gluten wheat peptides. While 75% of the peptides in wheat are gluten, 25% are these non-gluten wheat peptides. These non-gluten wheat peptides cause inflammation due to wheat sensitivity. In fact, some people are actually more reactive to wheat peptides than to the gluten itself. Another clinical pearl here is that when someone has reactivity in this panel, they often are reactive to other grains as well, especially corn. So if you're taking someone off of wheat and gluten, it's also helpful to run a grain zoomer and corn zoomer to make sure they're not replacing one sensitive food with another. Vibrant's Wheat Zoomer also includes 2 traditional biomarkers for celiac disease, which are tissue transglutaminase, TTG, and deaminated gliadin peptide, DGP. Thankfully, there is no indication that Jessica has celiac disease, nor any indication she's on the way to developing celiac disease. How can I know the latter? Well, in addition to TTG and DGP, Vibrant's Wheat Zoomer also includes the TTG-DGP fusion peptide. TTG cross-linked to DGP is a biomarker that allows for an earlier window for celiac disease initiation and diagnosis. In other words, it can identify celiac disease progression anywhere from 14 months to 4 years earlier than traditional lab markers. To answer the question, is this patient on the road to developing celiac disease? If you've never heard of the fusion peptide and are feeling skeptical, please allow me to share some research published in 2019 in conjunction with the Mayo Clinic's Dr. Joseph Murray. The paper is called Synthetic Neoepitopes of the Transglutaminase Deaminated Gliadin Peptide Complex as Biomarkers for Diagnosing and Monitoring Celiac Disease. The study identifies Vibrant Sciences as the owner of the microarray platform used to estimate antibody binding intensity of the tissue transglutaminase deaminated gliadin fusion peptide complex, and also references a 2016 study, also published by Vibrant and Dr. Murray, where the peptide array was first described. That is actually how Vibrant identified all of the wheat peptides measured on the Wheat Zoomer. So the big takeaway for Jessica is that her immune system was currently reacting to wheat and gluten peptides. Therefore, to reduce mucosal and systemic inflammation, she should follow a strict gluten-free diet. Since gut inflammation correlates with higher incidence of food sensitivities and intestinal permeability can increase the risk for food sensitivity development, we also ran a food sensitivity test for Jessica. Vibrant's food sensitivity test measures immune response to up to 209 foods and 57 food additives. And it's available as IgA and IgG antibodies or IgG4 antibodies plus C3d. We ran the IgA plus IgG test for Jessica, and she was reactive to many of the foods she was consuming daily, indicating to me that her leaky gut was allowing her to become reactive to the food she was eating all the time. So, in addition to the gluten-free diet, I used her food sensitivity results to create a personalized anti-inflammatory diet to help her decrease her symptoms by 50% in 2 weeks. While on the topic of food sensitivities, I want to take the opportunity to tell you about the clinical trial that Vibrant Wellness completed in 2024. In the study, 52 participants were tested for serum IgG and IgA levels against 262 food antigens. So the food sensitivity complete test in all 9 food Zoomers. Based on the test results, participants followed personalized elimination diets excluding foods they were reactive to for a period of 4 weeks. Symptoms were assessed weekly and seemed to decrease in 88% of participants from baseline to week 4 with a p-value of less than 0.05. The physician's evaluation of participants' responses were analyzed and showed 85% of participants saw notable improvements. Finally, antibody titers post-intervention showed improved IgG levels in 96% of participants, while IgA levels showed improvements in 85% of participants. In conclusion, serological assessment followed by a personalized elimination diet effectively addressed food sensitivity, evidenced by reduced symptoms, improved antibody titers, and favorable physician assessments of patient response. Note, this study is still in preprint, meaning it is in the process of but has not yet been given the final stamp of peer review. But it should be coming soon. The final stage of GI dysfunction is infection. The key markers of infection include inflammation markers, opportunistic overgrowth, and pathogens. Looking at Jessica's gut Zoomer results, we see that 3 of her inflammation markers are elevated. Her fecal eosinophil protein X was at 9.7, almost double the reference range of 4.8. Her MMP was 0.3 when it should be less than 0.2. And her beta defensin 2 was at 51.2 when it should be lower than 34.9. Looking at the gut inflammation infographic included in the Gut Zoomer report, you can see that fecal eosinophil protein X is produced by eosinophils as a result of exposure to parasites and allergens. If you remember, Jessica's had seasonal allergies since childhood. MMP9 can be made by neutrophils and macrophages in response to pathogenic bacteria and also the cytokines TNF-alpha and interleukin-6. Those same cytokines can cause epithelial cells to release the inflammatory marker beta defensin 2. However, epithelial cells also release beta defensin 2 in response to fungi. Foreshadowing here. Not surprisingly, Jessica's gut pathogens panel revealed high levels of Candida species. The reference range for Candida indicates it should be less than 110, but her levels were almost 3,000. Vibrant uses a real-time PCR machine for accurate identification of gut commensals and gut pathogens. Briefly, DNA is extracted and purified from stool samples. Then, we pair microbe genes with known complementary sequences called primers to identify which microbes are present. Primers are small fragments of single-stranded DNA or RNA designed to bind specifically to a single region of the microbe genome, allowing for precise amplification of the diagnostic target area. We then use probes to quantify the amount of each microbe. Probes bind to the target area and give off a fluorescent signal as amplification of that area increases. This fluorescent signal is then read by the quantitative real-time PCR machine, where the reaction is occurring to give a quantitative readout. The sensitivity and specificity of our primers and probes are quite accurate, ensuring high sensitivity and specificity. Additionally, Vibrant uses bead beating, enzymatic and thermal processes to remove biofilms, releasing the nucleic acids for analysis. Bead beating is an effective cell lysis method that disrupts virtually any biological sample by rapidly agitating it with a lysine matrix in a bead beater. Enzymatic and thermal processes use enzymes and heat to break down the cell walls and membranes, releasing nucleic acids for analysis. These additional steps increase sensitivity by reducing false negatives. In fact, this 2019 Gut Pathogens article affirms that Vibrant's Gut Pathogens panel has a sensitivity of 95.9% and a specificity of 100%. A specificity of 100% means there are 0 false positives. In other words, if a test shows you have a pathogen, you 100% have that pathogen. A sensitivity of 95.9% means there is a 4.1% chance of a false negative, so your patient may have a pathogen even if it wasn't captured by the stool test. Since Jessica's Gut Zoomer report indicated elevated Candida species, but not elevated levels of Candida albicans or Candida glabrata specifically, we also did a Candida plus IBS profile to learn which species of Candida she was reacting to. The test also explores whether food poisoning has shut down her migraine motor complex by measuring 2 antigens associated with post-infectious IBS. The Candida plus IBS profile is really a 2-in-1 test. Jessica's Candida plus IBS profile results indicated high antibody levels to Candida lusitanii and moderately elevated levels to Candida tropicalis, Candida dubliniensis, and Candida guillermondii. She also had moderately elevated antibody titers to cytolethal descending toxin B, indicating immune response to gastroenteritis, and high-risk antibody levels to vinculin, giving us indication that her migraine motor complex may no longer be working optimally. Indeed, the latter provides evidence that a bout of gastroenteritis has likely contributed to Jessica's IBS symptoms. The presence of high antivinculin antibodies suggests that autoimmunity that damages the gut function has developed, giving us additional insight into the root cause of the altered microbiome we're seeing on Jessica's Gut Zoomer results. And note that levels of antivinculin do become elevated about 3 to 4 months after infection and can be more persistent than levels of anti-CDTB. Let's do a quick overview of how food poisoning can turn off the MMC via molecular mimicry. Starting on the left, anytime you get a foodborne illness from E. coli, Salmonella, Shigella, or Campylobacter, those bacteria produce cytolethal descending toxin B, or CDTB for short. To help you kill these pathogens, your body makes antibodies against CDTB. Unfortunately, CDTB looks a lot like the human protein vinculin. And through molecular mimicry, the body ends up making antibodies to vinculin. Now, vinculin is a protein that helps nerve cells stay connected. Without going into all the detail, autoimmunity against vinculin impacts the interstitial cells of Cajal, ICC, which regulates your migrating motor complex, your MMC. Therefore, when your body attacks vinculin, it indirectly shuts off or reduces your MMC. And when your MMC isn't working, this allows bacterial overgrowth to occur, specifically bacteria like E. coli Q12, Desulfovibrio, and Klebsiella. Those bacteria go on to produce 60 times the amount of gas as a healthy microbiome, resulting in symptoms like gas and bloating immediately after eating, all of which Jessica complains of. Now, if you want a full 45-minute lecture on these mechanisms by SIBO expert Dr. Mark Pimentel, check out reference number 1. Looking back at Jessica's gut tumor results, we do see high levels of E. coli and other LPS-producing bacteria like Desulfovibrio piger and Bacteroides vulgatus. E. coli and Rhamnococcus navis are both biofilm-producing bacteria, so I made sure to add products to break down biofilms when we got to the killing phase of Jessica's protocol. I also noted several mouth bacteria, Streptococcus species, and Bacteroides vulgatus. Now, I know Jessica's brushing her teeth twice a day because she wanted to habit stat gargling after brushing. However, after seeing these results, I asked if she brushes her teeth before or after she eats breakfast. When she said after breakfast, I explained that mouth bacteria can reproduce while you're sleeping and that if you eat breakfast before brushing, you're essentially swallowing all those microbes that grew in your mouth overnight. And if you have low stomach acid, which is the first line of defense, or low levels of bile or not enough MMC, you may be contributing to bacterial overgrowth. In response to that, she quickly decided to start brushing her teeth before breakfast. I also took the opportunity to educate Jessica on the migrating motor complex, explaining that the MMC only happens in 90 minutes after the stomach completely empties. And the timer doesn't start when she finishes a meal, but when the meal has actually been chemically and mechanically broken down into chyme by the stomach and released into the duodenum. I shared evidence that MMC experts say the best way to promote a robust MMC is to fast overnight, 12 to 16 hours, and to allow 4 to 5 hours between meals. She told me, this is going to be hard, but she would try eating 3 meals a day instead of grazing throughout the day. I also recommended she take 1,000 milligrams of ginger before bed and use a product with therapeutic ingredients like artichoke, gentian, ginger, and magnolia, known to promote gastric emptying and motility. So, what was the final protocol for Jessica? Well, everything we just discussed. We started with nourishing keystone strains with prebiotic fiber, resistant starch, and polyphenols. We repaired her mucosal layer by avoiding reactive foods, using industry-leading blend of gut-soothing botanicals and nutrients to support a healthy gut lining and digestive well-being, and a spore-based probiotic to help bind all the LPS in her gut. We also worked to restore her vagal tone, which supports robust digestion, and by promoting a rested digestive mind, and also repaired her MMC by supporting motility with fasting overnight and also between meals. Then, once she was feeling better and able to tolerate the killing phase, she transitioned to an anti-candida diet paired with a round of antifungals, including caprylic acid, oregano, and berberine, as berberine has been shown to support both the MMC and Akkermansia, as well as having antimicrobial properties. I also included enzymes and products to help break up those biofilms. We used binders to prevent Herxheimer reactions as we killed the yeast. Again, we did the spore-based probiotic to bind the LPS. We also gave her liver support, so including N-acetylcysteine and milk thistle. And we also used N-cyclinic acid, which targets the hyphate component of Candida. Yes, Candida in your system can exist as a growing cell, but it can also exist in the hyphate form, which protects the yeast from typical antifungals. For an even deeper discussion on hyphae, check out episode 107 of the Less Stressed Life podcast, where Dr. Karan Krishnan and Arti Christabigler discuss Candida and fungal overgrowth in detail. In summary, functional gut disorders are driven initially by lifestyle factors that disrupt the microbiome, reducing diversity and weakening the immune system in the gut. Over time, changes in the gut microbiome and inflammation can influence the function of other GI organs, including decreased stomach acid secretion, fewer pancreatic enzymes secreted, decreased bile production, altered motility, leaky gut, and altered immune markers. Again, it's not a disease process, it's a functional digestive problem. When this progresses and the problem worsens, we see a weakening of the immune response, leading to an overgrowth of harmful opportunistic bacteria or an outright pathogenic infection. So when your patient has a functional gut disorder, the first step is to ask, is microbiome disruption present? You want to assess diversity indices and phyla balance, and the levels of both short-chain fatty acids, along with levels of the short-chain fatty acid-producing bacteria. We didn't have time to discuss this, but you can also look for metabolite high in beta-glucuronidase, which also indicates dysbiosis and warrants exploring urinary hormone levels and toxin exposure. If yes to the above, you want to support microbial diversity and metabolite production by increasing patient intake of polyphenols, fiber, fermented foods, and pre and probiotics, while also working on lifestyle factors like getting adequate sleep and especially stress management. Step 2 is to ask, is GI organ dysfunction present? Here, you're going to assess digestion, including pancreatic elastase, meat vegetable fibers, bile acids, and fecal fat, and also assess barrier and immune function by looking at secretory IgA, xylin, actin, LPS, DGP, and TTG. If yes to those, you'll want to support digestive and barrier function using enzymes, bile support, nutrients, mucosal healing, and perhaps even gluten-free diets if indicated. Step 3 is to ask, is infection or overgrowth present? You'll want to assess pathogens as well as opportunistic overgrowth, paying special attention to inflammatory markers like beta-defensin 2, eosinophil protein X, and MMP9, which provides insight on triggers and immune cell involvement. If yes to opportunistic overgrowth, you want to, well, do all of the above, and the overgrowth should resolve naturally on its own. If yes to a pathogen, most of the time you still also want to do all of the above, and then address the infection last. However, of course, depending on the pathogen, like Entamoeba histolytica, which can cause liver damage if the trophozoites perforate the bowel, you may want to eradicate the pathogen immediately. So it's really a case-by-case situation here. Other tests that pair well with the gut zoomer include the wheat zoomer, which is used to investigate serological markers of gluten and wheat sensitivity, along with markers of intestinal hyperpermeability. The food sensitivity test and food zoomers, as intestinal permeability can increase the risk of food sensitivity development, and gut inflammation does correlate with a higher incidence of food sensitivities. More things get into the immune cells when the barrier is not intact and does not have integrity. Vibrant offers 9 food zoomers. These measure reactivity to the peptides created from digestion of whole proteins. While many clients can get over whole protein food sensitivity reactions by simply improving digestion, in my experience, they often have to avoid reactive peptides for life. Also, the Candida plus IBS profile to investigate the serological response to Candida species, and also the presence of anti-CDTB and anti-vinculin antibodies, which are antigens associated with post-infectious IBS. When gut zoomer results indicate an overgrowth of beta-glucuronidase producing bacteria or elevated levels of just beta-glucuronidase, consider ordering the hormone zoomer to investigate estrogen levels as well as liver detox pathways. And when gut zoomer results indicate intestinal hyperpermeability and elevated beta-glucuronidase, consider investing in the total tox burden, which includes environmental toxins, mycotoxins, and heavy metals tests. This is used to investigate and reduce toxin burden, which contributes to GI irritation and also congests liver detoxification pathways. If you're looking for a full-service lab partner, Vibrant makes it easy for you and your patients. From one simple portal, you can order tests across a broad menu, more than 40 tests, all shipped in one box with streamlined instructions. Vibrant is a CLIA-certified, CAP-accredited biotech lab backed by 400 clinical researchers and cutting-edge technology, including the RT-PCR we talked about earlier, as well as mass spectrometry, microchip arrays, and more. We believe that anyone can achieve better health and vibrant longevity through individualized solutions based on testing, not guessing. Our peer-reviewed research featured in internationally renowned publications, including Nature and the studies I highlighted earlier in this presentation, a total of 52 publications and counting, has led to breakthrough products and services in celiac disease, allergies, immune disease, tick-borne disease, and more. And the support doesn't stop at testing. Concierge blood draws, complementary clinical consults, and powerful digital tools make it easy to integrate Vibrant into your practice. If you're ready to get started, follow these easy steps to sign up. Visit www.vibrant-wellness.com and click the Sign Up button in the upper right corner to create an account today. Thank you for your time and attention. Please let us know if you have any questions. This webinar is for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guests and hosts are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you have heard here today.